Let's go ahead and move on to House Bill 2113. We'll start with the staff report, please.
Thank you, Mr. Chair, members of the committee. I'm Kim Widener, staff to the committee. House Bill 2113 modifies the level of supervision required for certain radiologic technologists performing parenteral procedures. The Department of Health certifies a number of different radiologic technologists, including diagnostic radiologic technologists, therapeutic radiologic technologists, and MRI technologists, who perform specified tasks at the direction of a licensed practitioner. These three types of radiologic technologists may perform radiologic parenteral procedures when performed under the direct supervision of a physician. A common parenteral procedure performed by radiologic technologists is the use of IV contrast and imaging procedures. Department of Health rules define direct supervision as a physician who is on the premises and is quickly and easily available. House Bill 2113 splits the supervision required for IV contrast procedures and other parenteral procedures into two. Under the bill, IV contrast procedures performed by these radiologic technologists may be performed either under the virtual direct supervision of a physician through real-time interactive audio and video technology, or under the direct supervision of a physician, advanced practice registered nurse, or physician assistant. Other parenteral procedures may only be performed under the direct supervision of a physician. Finally, the bill provides that before these radiologic technologists may administer intravenous contrast agents, clinical staff with the requisite training and qualifications to respond to an adverse event must be present on the facility, which is similar to existing rule requirements. Please let me know if you have any questions.
Do we have any questions for staff? Okay, Representative Engel, please tell us about your bill.
Thank you, Mr. Chair. This bill I'm excited to bring to you today started with a call from a constituent who works at the hospital where this became an issue, where an attorney found in the law that in order for ARNPs and PAs who are allowed to operate in emergency departments as the solo practitioner at times are not allowed to be the supervising practitioner for CT scans with IV contrast. And you really cannot run effectively an emergency department without the ability to do that procedure. If someone comes in with a stroke or appendicitis, they need to be able to do this procedure quickly. So effectively, when they found in the law that you have to have an MD on site in order to do these procedures, it precludes those hospitals from utilizing these staff who they've been allowed to use for the past 20 years. And so as a result, I met with Department of Health, who confirmed that yes, that is the case. This attorney brought it to them. They had to agree that the law needs to be fixed. Then I met with all 8 hospitals that are in my district, who all agreed. Most of them don't have this issue right now, but many of them have in the past had to rely on advanced practice providers and recognize that someday in the future they may have the need to do so. And so then I've searched for anyone who's had an issue, hundreds of conversations. It's been a fascinating experience trying to get people on the same page, and I feel like we have managed to create a high-quality piece of legislation here that satisfies most of the concerns that have been raised. And one hospital radiology department I met with, the radiologist tech, had explained that they are comfortable with ARNPs and PAs, but they want to make sure there's somebody on site who can treat a reaction, because these can be crucial if you don't have someone on site who can do that. I believe the bill addresses those concerns. Some of the key points: there's no change from existing practice in many of our hospitals. This protects access to care in rural areas without increasing costs. Without this bill passage, many of our hospitals will have to hire more physicians, if they can even find them, in order to continue treating patients in their emergency departments. And this bill complies with CMS standards. I encourage your support.
Okay, great. Any questions for our prime sponsor? Okay. Seeing none, we have some folks here in person. Vice Chair Lacana, if you can call those folks up.
Thank you, Mr. Chairman. Let's do Troy Bender, Dee Bender, and then let's do Katie Cullen. And then on deck, let's have Edward Kim, and then we'll close out with Jim Hendricks.
Okay, welcome to our panel, and whenever you're ready, please state your name for the committee record to proceed.
Good morning, Chair Bernowski and members of the committee. Thank you for the opportunity to testify today in support of House Bill 2113. My name is Troy Bender. I am a PA practicing in rural emergency medicine here in Washington State. I'm honored to speak as Legislative Chair and President-elect of Washington Academy of Physician Associates, and I'm here to strongly advocate for the passage of this critical legislation. Let me start by sharing what this bill really means. It's 2 a.m. in a rural ER, and a gentleman comes in, someone's father, someone's husband, who comes in with severe abdominal pain, unexplained weight loss, signs of internal bleeding. Family is worried. I examine him. I know he needs a CT abdomen pelvis with IV contrast. Under this current law, I can't order that test. So this father sits in my ER in pain, his condition potentially deteriorating. I try to transfer him, but the receiving hospital won't accept him because without a diagnosis, they don't even know if they can handle him. So this man is stuck. I'm stuck. We're both stuck. And time is slipping away. With a simple CT, I can discover within an hour that he has acute diverticulitis with perforation. I can arrange for immediate transfer to a surgical hospital, and his family has the answers. He gets the care he needs, and he gets to go home to his family. This is someone's loved one. This is someone who matters, and it could be you in my ER. I want you to remember that. House Bill 2113 addresses a fundamental healthcare access issue in Washington State. Many rural hospitals do not have physician presence 24/7 and rely on PAs, nurse practitioners, CRNAs to deliver essential care in their communities. This bill ensures that PAs and APRNs can order the necessary diagnostic testing to properly evaluate and treat all patients seeking health care in our state without unnecessary delays or barriers. Importantly, this is not new territory. Federal CMS regulations already authorize PAs and APRNs to order these tests. House Bill 2113 just simply aligns Washington State with what is already standard practice at the federal level. It removes conflicting state-level restrictions that impede patient care. The financial reality for rural hospitals cannot be ignored. Most do not have the resources to employ physicians around the clock. Without this bill, we are placing an undue financial burden on hospitals that are already on the verge of closing, threatening access to care for entire communities. I encourage you to pass House Bill 2113 forward and ensure that no family has to endure preventable delays in care for the people they love. Thank you.
Thanks. Any question for our panelists? Okay, moving on. Whenever you're ready, please proceed.
Good afternoon, Chair Brunowski, members of the committee. For the record, my name is Dee Bender. I am testifying on behalf of the Washington Association of Nurse Anesthesiology. I am also a hospital commissioner in a rural county, Snohomish County. I'm in support of House Bill 2113. For decades, Washington hospitals, clinics, and facilities have employed advanced practice providers who have safely been ordering and supervising life-saving diagnostic procedures. Last year, a new interpretation raised questions about the supervision of radiologic procedures. When several rural facilities came under scrutiny for allowing PAs and APRNs to supervise the procedures that they had been overseeing for years, the Department of Health recognized the need for clarifying legislation to align the statute with the long-established practice that we've had. I want to commend Representative Engel for the extraordinary effort that he invested in this legislation. Representative Engel went to great lengths to understand this very complex issue. He worked tirelessly with every stakeholder imaginable: physicians, non-physician providers, regulatory agencies, hospital association, hospital CEOs, insurance companies, radiologists, the list goes on and on. The bill before you today represents collaborative work and the collective efforts of all facets of our healthcare system working together. This is exactly how healthcare should function, as a unified team solving access issues, addressing cost concerns, and ensuring safe and effective care for all Washingtonians. This bill exemplifies what we all can achieve when we put our patients first and work collaboratively rather than in silos. The current language of this product represents countless hours of negotiation, compromise, consensus building among diverse stakeholders who don't always see eye to eye. But we found common ground. Because we all recognize the importance of maintaining access to quality diagnostic services, particularly in our rural and underserved communities where advanced practice providers are essential to healthcare infrastructure. Without this clarification, we risk disrupting established care patterns that have served our communities for decades. Rural facilities may face impossible regulatory burdens, and the patients may experience unnecessary delays in receiving critical diagnostic services. I'm proud that we carefully negotiated this bill, and I ask you to advance the bill with the current language that represents a hard-won consensus, and it deserves to move forward unchanged. Thank you for the opportunity to testify.
Thank you. Any questions for our panelists? Okay, moving on. Please proceed whenever you're ready.
Mr. Chair, members of the committee, thank you again for the opportunity to testify in support of 2113. On behalf of the Washington State Hospital Association, I don't know that there's too much more to be said, so I'll keep it brief. This is a great thanks to Representative Engel and a great thanks to Representative Parsley for your patience while we've worked on this bill. It is a different version than what you've seen last year, and again, there's been a lot of work to date, and much appreciated for all of it. We appreciate the committee's consideration of the change in law. Physicians to provide direct supervision of virtual, direct, real-time interactive audio and video technology, and allowance for ARNPs and PAs to provide direct supervision of administration of IV contrast. The State Hospital Association supports this expansion and the flexibility. We've been looking for it. It makes a lot of sense to us, especially in rural areas, for the reasons already said by my fine panelists at this table, and we appreciate the sponsors' efforts again. So please recommend passage. Thank you so much.
Thanks. Any questions for our panelists? Okay, moving on, we'll dismiss this panel and we'll move on to the next. Jim, you're in person, come on up to the dais, and while you're moving up here, we'll move on to Edward Kim. Edward, whenever you're ready, please state your name for the committee record and proceed.
Oh, thanks. My name's Ed Kim. I'm here speaking on behalf of the Washington State Radiological Society. We are a professional organization of over 800 practicing radiologists, physicians who supervise, perform, and interpret imaging studies. Our members are often the physicians who are, in many situations, the first healthcare provider to diagnose and manage contrast reactions. Overall, and I speak on behalf of WSRS, not my employer or any other organization. So as an organization, we are supportive in general of House Bill 2113. We agree that it will improve access to care for patients. Appreciate all of the excellent work that's been done putting this legislation together. We would suggest, so I did testify primarily because we would support a practical amendment to add a distance or proximity requirement, primarily for the virtual supervision component for physicians. The use of a distance stipulation is pretty common practice in healthcare among physician groups who provide call. For instance, I practice in Seattle. When I'm on call, the terms of my call agreement specify that I cannot cover call from Olympia or outside a certain distance from the hospitals that I'm covering. If needed, we think that a supervising physician should be close enough that they can travel to the facility within a reasonable time frame to provide in-person care if needed. In the event that the physician does not need to travel to the procedure location, which admittedly would be most circumstances, we still think that it would be important that the physician who's providing virtual supervision would be familiar with the resources and healthcare infrastructure available to help manage a contrast reaction. We are concerned that it may be difficult for a physician located on one side of the state to effectively manage a contrast reaction for a patient on the other side of the state. They might not even know where the closest emergency room is. I'd also like to note that this does not affect the portion of the bill that relates to nurse practitioner or PA supervision, direct supervision of contrast reactions. Our comments are primarily limited to just the practical application of virtual supervision by a physician. Thank you.
Thank you. Any questions for our panelist? Representative Engel has a question for you.
Thank you, Mr. Chair. So when you're on call, I'm assuming that means that you have to physically be able to go in person to treat a patient or to respond to that. Is that correct?
Typically, yes. Not always, but typically.
And so I'm just trying to understand, like on this particular situation, what the justification, like if you are understanding what's going on here. Also, the bill requires us to have someone on site who's able to treat the reaction in person as well. So I'm just trying to figure out why the 30 miles would improve patient outcome. Normally, I think you would need someone who would be able to get on scene faster than 30 miles away.
I think it depends. It's possible that, so the physician is still the person who's kind of supervising and maybe directing the team that's on site, what to do as far as which medications to administer. But sometimes, I guess I'd say with remote medicine or telemedicine, there are a lot of services that can be handled very effectively, but there are still some situations where physician might say, well, actually, I really want to come in and lay eyes on the patient myself. Again, the other consideration is just that from a practical standpoint, we think that it is helpful if the physician is a member of the community who knows where all the different tools are that are needed to manage a contrast reaction versus, like for instance, if I were trying to supervise a contrast reaction for a hospital, let's say in Bellingham, like if it was a hospital in my community, I would know, okay, you're in this part of town, you need to go here. You need to go to this emergency room. I can call that emergency room and say, this is what I'm concerned about. Whereas if it's in a community where I don't know the resources that are available, it's just more challenging. I don't know. Yeah.
Any further questions for our panelist? Okay, moving on. Thank you very much. Jim, whenever you're ready, please proceed.
Hey, thank you, Chair Badonsky, members of the committee. I'm Jim Hedrick here on behalf of 800 radiologists statewide, including Dr. Kim. I'm essentially here in case his 2:30 patient ran long, but I will be very quick. Want to thank all the work that Representative Engel has done, all the work that Representative Parsley did on a similar bill that we offered last year. House Bill 2113, as we've discussed, modernizes outdated supervision rules that currently restrict when and how radiologic technologists can perform procedures involving contrast. This bill, as we've discussed, aligns Washington with current clinical practice and federal supervision rules. Just want to make it clear that CMS only made the virtual direct supervision rule permanent starting January 1st of this year. It was on a year-to-year waiver, came out of COVID, was on a year-to-year waiver. Now it is permanent. So this change in law would be permanent. It's consistent with CMS rules. Bill faces, we're facing a growing shortage of radiologists in our state. By enabling virtual supervision and broader supervision practicing categories, we make efficient use of scarce physician resources. In short, 2113 increases access, maintains patient safety, and updates supervision rules to reflect modern healthcare delivery. Thank you.
Thanks. We do have a question for you. Representative Parsley.
Thank you, first off. I appreciate your testimony and the doctor prior to this. I'm just a little curious, if CMS is allowing virtual supervision, why the 30 miles?
The 30 miles, I don't think that a lot of people have made something about the 30 miles. We're not making it up. It is in some of the service contracts, not just for virtual supervision of IV contrast, but it is in some of our service contracts of radiologists with some of our hospitals, some of our clinics. For the purposes that he said, it is to, you're more likely to have a physician who would be more familiar with the on-site staff, be more familiar with the healthcare infrastructure in the area, and direct patient safety guidelines, regulations, what have you, better.
So if I may, can I do one follow-up? So if we're doing virtual care, you would assume the radiologist would be speaking with the PA or ANRP in this situation, and those two potential would know the facilities nearby. They'd be very familiar. So it seems to me that would be, in lieu of 30 miles, you would have their expertise. Am I correct?
You would have, and Representative Engel has made it so in the bill last year that you would have trained staff, yes, on site that would address a patient adverse reaction. That's correct.
But also understanding the knowledge of the local facilities and transfers that could happen.
One could assume so.
Mm-hmm. Okay, Representative Marshall has a question for you.
Thank you, Mr. Chair. So for the adverse reactions that I think most of us are concerned about, it would be the severe anaphylactic reaction to the IV contrast. Is there something that having a physician able to respond within a certain period of time outside of the hospital that you believe would actually have an objective difference in the patient's outcome, having the physician there versus just somebody who's ACLS or code certified on a code team?
I think that was probably a question for Dr. Kim and not for me, but a fair question, but I'm not I'm not equipped to answer that
Dr.
for you.
Kim, can you answer the question? I noticed you were looking to answer a previous question as well. Whenever you're ready, just go ahead and proceed.
Sure. Yeah. No, I was just going to say that. So sometimes, patients may have an allergic reaction immediately. Sometimes they may also have a reaction that evolves over time. Patients may need to be observed for a certain time period if they have a mild reaction to ensure that it doesn't progress to a more severe reaction. So those are things that could evolve. Not just a reaction doesn't always happen just immediately. It could happen in the hour after a patient's given contrast. So there's a variable time frame for when a physician may intervene. Maybe going back to the other comment, I would say that if an APP is on site, they can provide direct supervision, so there doesn't need to be necessarily virtual supervision by a physician. The virtual supervision would be for a situation where maybe there's a nurse and a radiation technologist on site. Probably not so much in a hospital setting, but maybe in an outpatient facility where currently patients cannot get contrast scans unless a physician can be physically located at that facility. But thank you.
Any other questions? Okay. Seeing none, thanks to our panel. Appreciate it. We'll go ahead and close the public hearing on House Bill 2113, and we'll move on to House Bill 2168 with the staff report, please.